So, Mr. Chairman, Monsieur, Messieurs, my name is PAYEN. It's a very well-known name because of Michael Schumacher, who was the former driver of the Formula One in Monza, and Nino Stocchetti, and the other speakers from Italy will probably say a good word about the perfusion of the brain. So my cousin did a nice job, and I tried to do something of the cerebral perfusion, but I'm in a less junior level than Jean-François in Grenoble. But instead of this level, which is not good as Jean-François is, I will do my best to say somewhat about the perfusion. Of course, I have a conflict of interest with my brain, which is always insufficient. I'm pushing all the time and putting some stimulating things, but doesn't work very well. So 3 or 4 major parts of the speech will be, first of all, the useful concept that you know very well probably, but sometimes it's good to refresh. Then we move to the assessment. And you know the perfusion means what? It's oxygenation to the tissue, adequate diffusion of oxygen everywhere. It's a blood flow. It's a pressure, perfusion pressure. It's a combination of all. It's not easy to know what exactly means perfusion. We don't know what it means, but we know that we want to improve it all the time. And that's a major issue. And you have the arterial pressure, which is supposed to be the most potent one to push blood through the brain and the skull. Then you have something which is the CVP, the cerebral vein pressure, which is supposed to be the opponent pressure for the arterial one pushing, and there is someone braking, and then going to the drainage in the venous side. And each time you get the intracranial pressure, which is superior to the venous pressure, you squeeze the vein and then you stop the flow. This is the concept of the waterfall phenomenon, and the surrounding pressure may change the resistances, even you don't change the vasomotor tone. It's only a compression issue. Okay. The second concept is, you know, this so-called autoregulation that everybody knows, but in my institution, because maybe of my teaching which is not good enough, asking to the resident, tell me what means autoregulations, and I have several different answers. The answer is the flow remains constant in a large range of cerebral perfusion pressure. That's it. Which means that if you increase the pressure, you see the flow remains stable, then you reduce the caliber of the vessels, you constrict. Then if you reduce the blood pressure or cerebral perfusion pressure, the caliber goes up, you dilate, and the flow remains stable. That's true in physiology. The textbook is telling you that. But we don't know in acute situation, in acute brain damage, if we have still small areas or big areas which are losing this property of autoregulation. And then what's going on when you have an acute inflammation, a systemic acute inflammation? Does this inflammation changing the autoregulation capabilities of the cerebral circulation? So since you don't know with one point where you are, you should test variations in perfusion pressure up and down reasonably to see if you have a perfusion index like a transcranial Doppler, see what happens for your variation in perfusion pressure. Sometimes you increase the pressure, you see the intracranial pressure, for example, goes down. That means you reduce the caliber, you reduce the cerebral blood volume, then the intracranial pressure goes down. That's how the regulation works well. Or, on the other side, you can do that, and you see you reduce or you increase the pressure. Increasing the pressure, you see the flow goes up or the ICP goes up. So you lose the outer regulation. And then we can have both in the same brain injury, depending on the severity of the lesion you have. And that's a major point which has to be tested regularly, multi-times every day, to understand if you still have or don't have outer regulation and where, if it's possible. Then I'll skip this one because I explained well before. So what means the perfusion, cerebral perfusion pressure? This is the inflow pressure minus the outflow pressure. I told you before that the venous pressure can be the outflow pressure if the intracranial pressure is lower than the venous pressure. But when you have a higher cerebral pressure, intracranial pressure, then the venous pressure might not be the outflow pressure. And then you have to deal with arterial minus intracranial pressure. Then, is it an issue for the patient? Yes, of course it is. This is just a very old example. Here you see the arterial pressure was around 100, 90, 95. You see the ICP was around 30, 35. And then suddenly the ICP went up for any reason and going to reach the level of 60. With this 60, with small variations in the inflow pressure, you reduce the perfusion pressure to the brain. At this time, what we did, we decided to test the increase in blood pressure to test if outer regulation works or not. Then we gave norepinephrine, and you see here the intracranial pressure which is going down. It's a couple of minutes, it's a 4 or 5 minutes. And you see, boom, going down at the lower level than before. The arterial blood pressure went up a bit, but the intracranial pressure went down largely. That means that in this patient, you have still outer regulation phenomenon which works well, constriction, reduction cerebral blood volume, low compliance, and the variation of 0.2, 0.3 ml of blood inside the skull goes down the pressure inside the skull. Very efficient. Okay. The other point which is important is the CO2. We speak about the CO2 with the lung for many years. Everybody knows that. We don't speak too much for the CO2 for the splanchnic circulation, which is a major issue with the laparoscopic surgery, for example, but we don't speak about that too much. And then we speak about the PCO2 for the brain, of course, because the CO2 is the most potent vasodilator product we produce ourselves. Hypercapnia, acute hypercapnia, is dilating acutely the cerebral vessels. Then, if you dilate again, you get a higher blood volume. And if you have a reduced compliance of the brain, then higher blood volume, higher intracranial pressure, and then you precipitate potential ischemia because of that. If you reduce the PCO2 too much, you constrict. Then you reduce the blood volume, you reduce the intracranial pressure, but you are not perfusing too much the brain. So far you get an ischemia by perfusion or an ischemia by compression. So you have to keep the CO2 constant. 1 millimeters of mercury is an issue. Constant. Which means that this has to be carefully monitored all the time with a very narrowed alarms. Very, very, I'm paranoid with this. Not only with this, but also with this. Just an example here. You have the PaCO2, 45 millimeters of mercury. ICP, intracranial pressure, 44. Cerebral perfusion pressure, 54, which is not great. High ICP, not good cerebral perfusion pressure. CBF with a xenon clearance, 60. Not bad. Are you doing something? Who wants to do something? Raise your hand. Some people raise 2 hands. I have 3, and I do with the 3. Okay, what do you propose? To reduce the ICP? To reduce the PCO2? Okay, let's go. The people decided to decrease the PaCO2 from 45 to 30. Are you happy with? You are not happy with. That's crazy. Come on. Assassin. ICP was improving from 44 to 15. Are you happy with? For this point, yes. But the flow went from 60 to 14. Are you happy with? No. So in other words, as for the other circulation, as for hemodynamic, nothing is good, nothing is bad. It has to be integrated. You need a monitoring for all, otherwise you do mistakes. You ventilate the patients, you look at the screen of your monitoring screen, you are very happy, suddenly, ICP went up. Why? I don't know. Here the end-tidal CO2 is okay. The cerebral perfusion pressure goes down because the intracranial pressure goes up, and the arterial pressure was not sufficiently elevated at this time. We got cerebral edema. Testing the mannitol because we know the history of the patient. Fine, that's good. A couple of hours after, we got the same intracranial pressure elevation. But here we have an explanation which is different. You see the end-tidal CO2 goes up because of a stupid bubble trap which was full of having some rebreathing in the expiratory branch of the respirator, and then you get a rebreathing, elevated CO2, dilation, increase the blood volume in the brain, increase of the pressure in the brain, and you get a huge intracranial pressure elevation. It's not the same treatment. You have to treat the bubble trap. It works very well. So PCO2 is an issue. How do you assess this? Since it's an integration between all the parameters, you should monitor the blood pressure carefully. You should monitor the perfusion with the transcranial Doppler. We should monitor the CO2 with the end-tidal CO2. You should monitor the intracranial pressure, and you should monitor the extraction of oxygen, having the SVGO2. You do what you can do. The best is to get all, but sometimes you cannot. But you have at least 2 or 3 of them, which are very essential to make a decision. You know the ICP technology. You know the transcranial Doppler. This is a machine that I don't understand, that we have only in France 6% of the ICUs having a transcranial Doppler. That's something I don't understand. Is the price lower than the mechanical ventilator? It's essential to know what's going on in the brain injury, or the brain as a potential victim of another injury, and we don't have this. It's absolutely crucial. Okay, you measure the blood velocity. It's not the blood flow because you don't have the caliber of the vessels. But look at this. The middle cerebral artery is really in front of your transducer. And it's a pulsed Doppler technology. That means that you are knowing very well the depth at which you measure the flow velocity. It's not a continuous Doppler like you use for aortic blood flow velocity. Okay, then what should you look at? You look at the systole as you do usually, but the diastole is always positive physiologically. You should have a diastolic blood flow velocity. That means that during the diastole, the passive flow has a positive flow because of the very low resistances downstream the measurements you do. If it's going to be smaller, that means that the resistance to flow is increasing, whatever the mechanisms of this increase, compression, obstruction, constriction, whatever, but you reduce the diastolic flow. This is the key parameter you should assess. Okay, the normal value has to be between 30 and 40 centimeters of second. Of course, this has to be integrated with a sedation or not. Now, for example, for me, my diastolic blood flow velocity is probably high. And looking at Nino, I'm putting more diastolic blood flow velocity because I'm excited more. Then I will sleep after. I'm going to 30. I will take care of that, Nino. Then you see the compression here, you see the diastolic velocity here, and then the intracranial pressure goes up. and you see finally you don't have any flow during diastole. It's extremely sensitive methodology to know what happens. Many years ago, we used this to diagnose the brain death situation, which is sometimes very difficult to assess. And some people in England say that the backflow, the early backflow, was a criteria for brain death. It's totally wrong. Forget it. Many people are still working, and one is a deputy and had in the ICU this backflow in London. So finally, it's not a criteria. And you see the residents are highly resistant because they continue to tell me he's in brain death because of this. No, does not prove you are in brain death. The brain death means no diastolic flow. Here, this is the end of diastole, and it means that you are with no flow during diastole. And this has been shown with a testing and training cohort, and we've showed that there is no overlap between the end diastolic velocity of flow with the people with brain death and people with severe brain injury. There is no overlap. It's extremely sensitive. We tested it first, and then second population was made. Finally, this is the technique we use to decide to transfer the patient for transplantation. It's a very efficient technology. SVGO2. Some people are using some now because the technique's not good, the catheters are not so great, are very expensive. You get a risk for thrombosis, not easy to put. Then you have to recalibrate. So make a decision if you really want to know what happens for the metabolic issues, but sometimes it doesn't work well. We published the validation of this retrograde measurements with the fiber optic. It was more than 14 years ago with Nathalie Clavier. It works well, and you can use it. It exists. For what pathology? The question I asked initially was, what do we know about the reality of the physiological concept applied to the pathological situations? In other words, when you have an acute systemic inflammation, what are the relationships between the cerebral blood flow physiology and the systemic hemodynamic? And that was the question we tried to address, because in the literature we don't find any data showing clearly what happens in patients. Then we tested this with two groups of patients, a group with acute systemic inflammation, and the best might be the trauma or the septic patients, versus the other one coming from post-op and then being well, and just before the extubation we did the measurements, or during the OR, during the surgery when they are anesthetized with the same drugs that we use in the ICU, and look at this normal situation, quote, normal situations. And then the objective was to see what happens if I'm changing the cardiac output for the blood velocity, if I am changing the blood pressure for the blood flow velocity. That was the goal. And you see here, the healthy people, the flow went up from 5.7 to 6.7 when you give fluid. You are not surprised. Mean arterial pressure was maintained. It's a normal physiological response. That means that you dilate the circulation when you give fluid. The systolic velocity went up a bit, not significantly, and the end diastolic velocity did not change. So in other words, the brain is separated from the systemic circulation changing with the fluids. If you go to the sepsis group, you see here you have the flow went up, the pressure, the heart rate did not change, the stroke volume increased, even non-significantly between the two groups, but the systolic arterial pressure went up more in septic patients than in non-septic patients. And then we have a huge increase in diastolic blood flow velocity when you have a systemic inflammation. That means that the brain is not controlling normally the impact of the systemic circulation, and it becomes to be more passive than it is physiologically. An example, trauma brain injury patients. You have here the SVGO2, you have here the intracranial pressure. You see it's very high, we are not happy with. And then talking with this, we measure 60 for the SVGO2, which has to be more than 75. The intracranial pressure was 33. You are not happy with this. You have to make a decision. What are you doing? Okay, we do that. The Doppler, you ask for me the Doppler. You see the Doppler, you have a, diastolic blood flow velocity is still there. You don't see very well, but it's around 16 centimeters per second, which is not great, but it's not catastrophic. But we should do something. What we did, oops, sorry, the animation didn't work. We'd give mannitol, and the mannitol was reducing the intracranial pressure. You see the SVGO2 moving to 75, and you see the Doppler, which is increasing the diastolic blood flow velocity. So with the three parameters going to the same way, we know that the mannitol was efficient for the patient. This is a thrombovenous cerebral situation. You know, the thrombophlebitis in the brain. Not so frequent, but extremely severe. You get a thrombosis in the venous side of the brain circulation, and here you have to monitor all the things. We did a craniotomy here, thrombectomy here, because of the parameters for monitoring which were not able to improve despite the good resuscitation. And look at this. When the thrombectomy was done, you see the cerebral blood flow velocity on the left and on the right. We double, which means a hyperemic response. So you get a higher flow that you expect, and the risk is to get an hemorrhagic or bleeding in the ischemic area. And then this was followed carefully during the day. The principles for the treatment, to summarize for the perfusion, are the following. First of all, we should control the CO2. We should reduce the oxygen consumption by doing some efforts, then sedation, intubation, mechanical ventilation, plus or minus hypothermia. Mr. Schumacher was put in hypothermia quite immediately when he arrived at the hospital. We have to avoid any variations in CO2. Stay around 40. I accept 41. I accept 39. I refuse 38. Optimization of the oxygen balance. So you reduce the most as you can the oxygen demand, and you try to better perfuse the brain, and then you do the best to maintain the perfusion pressure. Then you have a cerebral vasospasm in the bed after. This is another brain injury, so you know that. And finally, you have to treat the guys. And this is a multidisciplinary approach. The intensivist can say something happens. He looks not fine for many reasons, clinical reasons or monitoring reasons. And then you ask the neuroradiologist, which is able to do something, and he does. And he is doing something with mechanical angioplasty, but you can do the chemical angioplasty, and you continue to monitor what happens in the brain circulation. So finally, the chemical angioplasty. We developed a couple of years ago the milrinone. You know the milrinone, which is good for the at least it's used for cardiac failure, so we use that for dilating the vessels in the vasospasm. And sometimes it works better than the calcium entry blockers. Sometimes the calcium entry blockers are working better. And in addition, with the mechanical angioplasty, you can solve many problems. And you see here a clear effect of milrinone injected intraarterially compared to the vasospasm, which was a diffuse one. And the diffuse vasospasm means that you have to use a large drug going everywhere, more than the local one. So the milrinone works well intraarterially. Now we validated the use of this drug intravenously with a high dose of the drug, and it works and maintains the vasospasm treated during the perfusion time. So finally, you can do also the thrombectomy, and the thrombectomy is also something you should do for the locked-in syndrome when the patients are coming. And just to show you something, you reperfuse. The concept, and maybe the specialists have an explanation for that, is that even you arrive at the hospital later, but having a thrombosis of the posterior circulation, you have to do the thrombectomy even 24 hours after the beginning, because for the posterior localization, it's sufficient, largely more than for the anterior one. I don't know why, but that's the observation we did. And if you look at the results, we have only 5 patients over 20 who died, and 12 over 19 who had a very good recovery and going back to work and to live normally. So thank you for your attention for this presentation.